Good afternoon, everyone, and welcome to the Heart Quality Exchange. My name is Michelle, and I'll be your moderator for today. Feel free to ask questions throughout the presentation by either typing them into the Q&A box on the right-hand side of your screen or dialing *6 to unmute your line. If you would like to zoom into any part of the slides, please use the magnifying icons on the right-hand corner. Also, the slides and the link to the recording will be provided within 1 week. I will now turn the presentation over to Deb Moats. Deb, you have the floor.
Thank you, Michelle. Good afternoon, everybody, and welcome to the Stroke Quality Exchange. As hopefully most of you know, we do this quarterly after our DaytoDays, and I'll talk a little bit more about that. Oops. But for the agenda today, I'm going to talk a little bit about the stroke PMT release notes that were released in June and July. Talk about DaytoDays and what we do with that. We'll talk about our Southwest Affiliate Stroke Performance Measure report, and then the top 3 performance achievement measurements that are fallout. And in that area, during that time, I hope that people will share some of your experiences with this. And again, *6 to mute and unmute your line, or type it in the box, and Michelle will let me know. We're also going to talk about it, CSTK measure 4, and what would you do? I'll give you a scenario about that. I'm going to show you how to add hospitals to the PMT. I've had a lot of those questions. Then there's just a few did you know things that I'm going to share with you. The Texas Stroke Rules stakeholder meetings are happening now, and I'll talk a little bit about that, and then some educational opportunities. So I have a lot to cover, but if we don't get it all covered, it's all in the slides and the links are there, so that's fine. I would rather have you guys talk and give some information and exchange ideas than for me to present everything. So to start with, the stroke PMT update. There's a summary of updates that was released in July of this year. It was like the 11th, I think, or 12th. And in that update, the comprehensive form groups were updated. There were some Arkansas form group updates, and then it addressed some of the user-reported issues that we've had after the previous update, and then some of the operational issues. You should, every time that there's any changes or revisions, then you'll receive a letter from the RWLPR support team at Acuvia. So the emails will go to you. So anything related to this, if you want to go back and look at your emails, or if you can't find the information, I'll be happy to send them to you. Just let me know. And then June, the update was on the EMS elements in the Special Initiative tab. There were some critical error issues that was not allowing people to complete appropriately the fields and save them. So the PMT fix release for that was June 9th of 2018. And it does seem like every time we have a release, we find 1 or 2 things that are not working properly. So if that happens, be sure and let your director know if you're having any kind of issues, because we may not even know about it if you don't share that information with us. So the one email was actually sent to you on 7/11. That was the July 2018. And then the EMS Initiative 6 email was sent to you on June 11th. So again, if you need more information about those emails or the attachments, let me know and I will send those to you. So of course, as I said, whenever there's a release, we find another issue. And so there was an issue identified in the stroke PMT on the 20th of July. That issue is for stroke sites not configured with the EMS form group. There's been an issue which is resulting in certain errors related to the patient arrival field to fire when it's not applicable. The workaround for that is to save the impacted form as incomplete, and then if you reopen the form, the arrow will no longer be incorrectly firing, and the form can then be saved as complete. The resolution for that, they're working on scheduling a hotfix release for that, and that will happen on August 15th. And again, you will receive an email when that actually does happen. And, you know, we're really sorry that these things happen. But again, if you see issues, please let your QSI director know. So get with the guidelines DaytoDay. So what is that? It's been, I think, about a year now, or maybe a little bit longer even, that we have done the DaytoDay. And what we do is we receive a raw data file from IQVIA. So when we send out these reports, it's just a snapshot of that particular day that we receive that raw data form. You just need to remember that whenever you enter a patient in, or when anybody ever enters anything, then that's going to change your data. So whenever you look at things, again, it's a snapshot of the time that you're looking at it, and it continually updates. So in July 2018, just like 2 weeks ago or 10 days ago, then you should have received a report of the Q2 data snapshots. It would have been Q1 and Q2. If you did not receive that, then please either type your name and contact information into the chat box, or just let us know, because we want to make sure that you are receiving the reports that you need. So this is all the Get With the Guidelines data. If you're a part of that and not receiving reports, please let us know. In October 2018, we will be sending out the Q3 data snapshots. And we realize, you know, you're just finishing up in September. You're not probably going to have all your information abstracted, but again, it will give you an idea of where you are towards your awards achievement, because we really want to do everything we can to help you to, whether it's process improvement things or just looking at the data, or maybe some abstractor errors, but to be able to actually receive the recognition that you deserve while taking care of your stroke patients. In November of 2018, the gold and silver hospitals will be recognized at QCore. That's not stroke, that's all of our other programs. So that would be the heart failure recognition, the Afib recognition, and the CAD. Stroke is always recognized at the International Stroke Conference, and that will be held in February of 2019 in Hawaii. So that's when those awards will be recognized. And then in January of 2019, then we do the Q4 year-end snapshot. So that gives you plenty of time to know, to look at your information, to see if there's any abstraction errors, to correct anything that you're missing, to go back and review and drill down on those charts to see what is it that you missed, or what kind of education can you provide to, whether it be a provider, your staff, whatever. But that's just kind of a way to give you a step ahead, knowing that where you are as far as your awards, and that would be the Get With the Guidelines Gold Plus, silver, actually bronze, silver, gold, gold plus, silver plus, and then the Target Stroke Initiative. So the goal for deadline for completing your PMP records for calendar year 18 is February 28th to be considered for award. You do have some time in there, and I'll talk a little bit about that in another slide. You will have a little bit of time in there to be able to fix everything, but if you have February 28th, if you make that your goal, then you should have all of the information that you need. So if there's anything you need to go back and look at or drill down in, then you should have that opportunity. So now we're just going to review our Q2, what we learned from Q1, Q2. For the Get With the Guidelines Stroke Program, there's a total in our Southwest affiliate, which is 6 states. There are a total of 264 hospitals, and 233 of those hospitals have entered data. So there are a few hospitals that have not entered any information yet for this fiscal year. If you're having issues with that, then please let us know. We can maybe help you to troubleshoot or come up with some ideas, or maybe work with you on the uploader to save some abstraction time. So please let us know if you're having issues with that, and we are available to consult one-on-one with you and your hospital. So all of the QSI directors and the senior directors for the Southwest affiliate for quality and systems improvement. So utilize us as you need. So first of all, the achievement measures. This is showing you how many hospitals actually entered the information or that actually achieved that measure. And we're going to look at the aggregate, the gray boxes on here, because that's kind of when you get to your awards, it is an aggregate award throughout the whole year. So that's why we look at quarter one, quarter two to see how the changes are. I do see that there's quite a dip from quarter one to quarter two, but I believe a lot of that is just related to like I said, the early time that we enter that we receive our information. So you probably don't have all of the information, all of quarter two information is most likely not in these numbers. So I'm sure that they do improve. But the achievement measures, 91% of the total hospitals are reaching the 85% or higher achievement measure. The plus measures, there's 166 hospitals that are right now achieving plus measures, which is really good. And then the target stroke honor roll elite plus, there's actually 57 hospitals that are meeting that measure of the 264. The TSH elite, target stroke elite, is 34 hospitals that are meeting that. And the honor roll is 25 hospitals at this point, and that's just again through quarter two. So now we'll take a look at the individual performance measures to see kind of where we're at, maybe where we can use some help, maybe be able to provide some resources for you to utilize to help with your process improvement. So the first one, again, we're going to look at the aggregate numbers. So the IV arrive by 2 hours and treat by 3 hours, IV TCA, I'm sorry, is 69%. So that is not at the 85% level across the whole Southwest affiliate. And again, this is aggregate numbers for all of the hospitals that have entered data. The early MS thrombotic, we're at 86%, so just barely over 85, so of reaching that measure. VTE prophylaxis, we're at 84% as a Southwest affiliate. That just needs to be bumped up a little bit, and there's plenty of time to work out these details. Antithrombotics at discharge, 88%, so reaching that measure. The anticoagulation for Afib and aflutter, that seems to have come to the surface again this year as people having a few problems with that Afib or the anticoagulant measure. So we'll talk a little bit more in depth about that. Broken cessation is at 79%. The issue that we're finding with that particular measure is that a lot of people have stopped smoking, or so you may not have any patients in that particular measure. In order to reach the achievement award level, you have to have at least one patient and be over 85% compliant in order to be able to achieve the rest of the measures. And then the statin prescribed to discharge is at 84%, again, right at the 85% level. Then when we review our plus measures, dysphagia screen is at 71%, so continuing to have some issues with dysphagia screen. Anybody who has any great ideas or things that you've done with that, please feel free to share what you've done to help improve that measure. Stroke education is at 83%. That's the 5 things have to be charted, and it's all or none. Rehab considers it at 87%. That's actually, for these measures, I forgot to say, for the plus measures, the goal is 75% or higher, and at least 5 of these 8 measures. So at rehab, we're well over that, 87%. Time to IV thrombolytic therapy, 60 minutes, we're at 61%. So that's not quite meeting our measure. LDL documented, 80%, that's meeting the measures across the affiliate. Intensive statin is at 58%. That seems to be coming up, getting a little bit higher, but still needs some work on that one. Arrive by 2 and treat by, arrive by 3.5 hours and treat by 4.5 hours, we're at 69%. And then the NIH stroke scale reported is at 81%. So that just kind of gives you an overview of where we're at. And the two things that I noticed that I would like to just dig down into just a little bit more was the Arrive by 2, Treat by 3 measure, and Target Stroke kind of goes along with that, the Target Stroke Initiative, and then the other measure is the anticoagulation for Afib. So go into those just a little bit more. And please, this is where I would really, really, really like for anybody who has some things that you've done for your process improvement, you know, what have you implemented to help improve these measures so that we can help one another in our efforts to give the best care that we can for these patients and to save brains. So, oh, sorry, I missed one more. So the average for our Target Stroke honor roll measure, this is all of our hospitals included. So no matter if you had 1 TPA patient or if you had 6 or more TPA patients, you're included in this particular graph. So the time to IV thrombolytic therapy within 60 minutes is 61% currently. And again, for Target Stroke, we are looking to be 50% or higher at the 60-minute or less minutes, or 60 minutes or less for TPA door-to-needle time. For the Target Stroke Elite, it's 75%, door-to-needle 60%, and then the Elite Plus measure is actually, that measure is 45 minutes. So time to IV thrombolytic therapy, 45 minutes, should be at 50% in order to achieve the Target Stroke Elite measure. And all of that information is located on the bottom of your DaytoDay reports that we email to you. We do put the guidelines there so that you're able to refer to that. So again, for our average for all hospitals, we're at 61% in the 60 minutes, 34% in the 45 minutes. So, you know, we've got some work that we can do on that. There's been a lot of work done on it already, I know, across the systems, and it has been going on for several years. The Southwest affiliate averages for only those patients that are qualifying hospitals, and that means you have to have a minimum of 6 TPA patients in order to be considered for the honor roll award. So those that have 6 or more patients, for the 60-minute window, it's 80%. For the 45 minutes, it's 47%. So we're looking for 75 and 50%. So getting pretty close. We're getting very close. A lot of improvements have been made. And then to break it down, then the Target Stroke Elite Plus aggregate, we have 57. 57 hospitals are reaching that. 34 hospitals, the Elite, 25 honor roll, and there's 11 with no award at this point. The majority of the patients have a low, the majority of the hospitals have a low volume, especially because it's just quarter 1, quarter 2 right now. So that low volume award, low volume is keeping you from being able to be awarded this Target Stroke honor roll. So that's 106 of the hospitals at this point. So just to go a little bit further into it, one of the things that we have seen over and over in the Arrive by 2, Treat by 3 is that when you're marking your IV TPA, they're marking IV TPA was initiated, it would say no, and then documenting it in 0 to 3, what was the documented exclusions in the 0 to 3 window, and people are saying yes on that one, but then they're not hitting the show all. When you hit show all, then that will open up another window where you can actually document your exclusions. So that's what this is showing you. Make sure that you hit show all or you will not see the screen in order to document it. So we have been able to actually overturn quite a few of the Arrive by 2, Treat by 3 measures, only because people were not, some of the abstractors were not aware of opening up that window to include their exclusions. So make sure that you do select that exclusion so that that patient then would be excluded from the measure. The other thing that I've seen on several of the reports that I worked on was this greater than 60 minutes right here. So I've had people write in like initial refusal or maybe the care team was unable to determine eligibility, and that happens like when a patient comes in and maybe they're on warfarin and you don't know whether or not they've been taking it, or you don't even know whether it's possible they're on it and you don't really know whether or not they've been taking it. Or it could be the patient, maybe the patient's kind of refusing things, wanting to wait. They want to wait for somebody to come, then the initial refusal. Those options are available for your 0 to 3 windows as well. So I've seen people marking no that there was no exclusions documented, but marking yes that there's documented reasons for beyond 60 minutes. And those should be marked over here as well in your exclusion through the show all. And those will eliminate it. So just a couple of hints of things that if people are missing, that you know, just to kind of keep an eye on it will be very helpful for achieving that measure. The target stroke honor roll, we have that's the stroke 4 measure. So arrive by 2. Oh, sorry, I meant to take that one off. I already talked about that. But in 2010, the Target Stroke Honor Roll initiative was launched, and that was a time when, you know, we were looking at door-to-needle times across the United States, actually, all across, and the door-to-needle times are really very high. And so once this program launched and people started working on it and looking at lean ideas and looking at ways to cut time out, then there was a notable decrease from 74 minutes to 59 minutes. That's a 15-minute improvement. That's awesome. Overall, the percentage of patients treated within 60 minutes increased from less than 30% to more than 50%, and we're seeing a lot higher now. So this was probably about 2014 when we started to increase or started to work on the Target Stroke Phase 2. Patients treated within 60 minutes experienced improved outcomes, including lower in-hospital mortality and reduced long-term disability. So again, we know time is brain. The faster we can give TPA, if they qualify, then the better. Oops, I didn't mean to do that either. I don't know if I can do that. Nope, hold on. I just want to show you real quick some things that we have that are very useful, and this is one that I think is really pretty cool, so I just wanted to share it with you. It's just a short little video, but you could use it with your stroke teams to just kind of highlight some of these areas. So it's a 4-minute video, but it goes through all of the different things that you can do to help decrease time, things that you can consider.
The Target Stroke National Quality Improvement Initiative sure thinks so. We focus on improving acute ischemic stroke care and outcomes for eligible stroke patients treated with Altapreg. How are we going to do it? Simple. By reducing the needle time for every eligible stroke patient. The goals for Phase 2 are to reduce those daunting door-to-needle times to within 60 minutes and eventually down to within 45 minutes. But don't worry, during the video, we'll review the 12 key strategies to help us get there. Are you ready? Let's get started. So you want to know what matters most when someone suffers a stroke? The answer is simple. Time. No. Seriously, every second matters. We have a little saying with regard to stroke treatment. Time is brain. Cute, right? But really, it's no laughing matter. Every second wasted increases the risk of irreparable brain damage. No pressure, right? Thankfully, we've developed 12 key strategies that will help you save time and drastically affect your patient's recovery and peace of mind.
Hi, Deb. The video was going great, but now we've all lost audio.
Oh, you did? Can you hear it now?
Now we can hear it.
All right. Sorry.
a cheat sheet. The patient gets the proper care, and the attending physician has all the help he or she can get. Everybody wins. Key number 3, quick response triage procedures lead to earlier recognition of stroke and reduce time to treatment. Remember, we're counting seconds here, so mobilize your stroke team as soon as you receive a pre-notification or a stroke patient is identified. That's key number 4, implement a system where the entire stroke team can be activated with a single call. This single call system should include the reservation of a scanner for brain imaging. Still with me? Good. Still checking. I know it's a lot of information, but the clock is ticking. We better hustle. Key number 5, attach a timer or clock to patient's chart, clipboard, or bed. A universal clock allows healthcare providers to accurately evaluate the patient. Tick, 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 tick. Key number 6, if appropriate, transfer the patient directly from the triage area to the CT scanner for neural exam and brain imaging. The sooner the better. Key number 7, perform the CT scan or MRI within 25 minutes of patient's arrival and complete a full assessment of the scan within 45 minutes. Key number 8, lab results should be available no later than 30 minutes after patient's arrival. It's a fast-paced world. Everyone wants everything right now, and we're no exception. So if standard lab times are too slow, use alternate point-of-care testing for faster results. Yeah, we still got more to learn, but we're running out of time. Key number 9, mix the alteplase ahead of time. Prepare the bolus dose and 1-hour infusion pump as soon as the patient is identified as a candidate. Just FYI, the drug manufacturer will replace mixed but unused medication in time-critical situations, so preparing the drugs ahead of time can only help. There's virtually no downside. Key number 10, as soon as the patient is deemed eligible, administer the alteplase IV. The initial dosage should be given while the patient is on the CT table. Keep dosing charts and standardized order sets handy so they can speed up the process and reduce the risk of errors. Cheat sheets again, gotta love them. Key number 11, put your heads together. A team-based approach to stroke treatment can increase efficiency and care. Form a diverse team to review the hospital's processes and results. Key number 12, accurately measure and track performance times in stroke response and treatment. You won't be able to improve if you don't establish a baseline. Identify areas for improvement and then take action. Finally, include a process for prompt feedback to improve common practices. Tick, 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 and done. Whew. Not bad. Not bad at all. Now, that was just an overview of the 12.
Okay, so I think this is a nice little video that can really help people, some of the stroke coordinators here, to get your team of people together and review this, maybe work on a lean process or something like that to help to decrease your time and just monitor things. Just for your information, there's a lot more here learning about the target stroke, and then there's webinars and slide decks that you can click on there. And then if you just hit this target stroke, there's a whole lot of information here that can help you, including some clinical tools and resources and then some publications. So I just wanted to make sure that you were aware of these educational opportunities and these tools to help you to decrease your door to needle time. So I would really now like to open it up to see if any of you have implemented any of these, anything that you would like to share, any issues that you had, or what seemed to work the best for you when you were working on decreasing your door to needle times. And I know that this is happening across the country. So if you would *6 to unmute to ask questions or to share your information. Or if you don't want to talk, then send the message through the chat box to Michelle, and she can give me your message. So *6 to unmute. Please share your ideas. Nobody wants to talk. Okay, so the EMS providers is really important in this process, to include them when you're looking at your lean process. Maybe even have them attend some of your stroke committee meetings when you're reviewing your door to needle times and all the stuff that you do. For one thing, it probably will really impress them of the wonderful work that you're doing. And then just also excite them and let them know, how important this is, and so that we can all work together in the system of care to provide the best care possible. Another thing they mentioned was the timer. You know, even getting something like when I was a stroke coordinator, I just purchased a bunch of the little kitchen timers and just set the timer for 60 minutes at that time. Now we'd be setting it at 45 minutes. But that way it was just a visual thing that people could look at, and they knew right where they were, what time it was, and how much time they had left. And then another thing is with the labs. So if you have labs, chest x-ray, all of that stuff on your emergent order set, then the expectation is that those are resulted within the 45 minutes of arrival. But the thing is most of those labs, you don't even really need to make that decision on TPA or not. The biggest thing, the only thing you really have to have would be your glucose number, point of care glucose, to make sure that it's not a effect from the blood sugar. And then the other thing is if you know that the patient has a hypercoagulation problem or is on Coumadin or whatever, then getting the INR, getting the PT, PTT, and INR times, just so that you can see where they are prior to giving TPA. However, some ERs and some hospitals do not even wait for the INR. They will go ahead and start the TPA if they think that everything else is in line. And then when they get that back, which is usually just within a few minutes, then they can always stop that TPA. So it's just something to think about. So is there anybody think of anything else that they would like to share? All right, we'll move along. The other measure that we've seen a lot of fallout is the anticoagulation, Afib or A-flutter measure. So again, it's not a medical mystery. The issue is, I'm going to do another video here, but the issue, the issue is here that patients with AFib that are not treated with anticoagulant, if they can have it, are 5 times more likely to have a stroke than those that are treated with the anticoagulation. So that's a pretty hefty number. And if there's things that we can do to help prevent that, then that is exactly what we want to do. So I'm just going to do a short video. There is the program, Get With the Guidelines for AFib, and give you an overview of this particular program.
Get With the Guidelines AFib is a national quality improvement program by the American Heart Association to evaluate patients with atrial fibrillation and to initiate the appropriate management for them while they're in the hospital or in an observation status. So atrial fibrillation is a very prevalent disorder. There are about 2.7 million people with atrial fibrillation in the United States. About 75% of them would benefit from the use of oral anticoagulation therapy. And we know that we're only hitting about 50% of those patients. 50 to 60% of those patients are getting the appropriate treatment. What we're trying to do is to close that treatment gap, and I think we have a very significant opportunity to do that with Get With the Guidelines AFib. But we know that Get With the Guidelines is effective. We've studied the ability of Get With the Guidelines to initiate anticoagulation therapy for patients with atrial fibrillation in the stroke module, so we know that it works. But there are so many more patients that we'd like to get to before they have a stroke, and that's why we're initiating this module and Get With the Guidelines. So while we know it will be beneficial, and we know that we will be successful at this, we're trying to reach a broader audience. Get With the Guidelines AFib is not just a database. It's a whole set of things that make our quality improvement program really run very well. The first piece of that is the quality improvement field staff. There is one-to-one hospital field staff interaction to assure the best execution of that quality improvement module. The second part about this is the patient management tool. The online patient management tool is used to help hospitals guide therapy at the time the patient is in the hospital, that is concurrently, so that it's not a retrospective database. It's an active, concurrent data acquisition and quality improvement module. The next piece that is very important about the Get With the Guidelines program is from its inception, it was not designed to be a one-size-fits-all type of approach. We go into hospitals and we look at what your quality improvement programs look like, and we design the Get With the Guidelines program around your own quality improvement program. It is a rapid cycle quality improvement program. It's not just a database for gathering data. Better quality has always been associated with cost improvement and cost savings. When you look at the current process by which CMS is looking at readmissions for heart failure, for instance, we know that providing excellent quality in heart failure is going to actually improve savings for a hospital directly. Get With the Guidelines Afib will look at those patients who have heart failure and help manage those patients better. Because the atrial fibrillation is controlled, the patient's readmission rate will be less and the ability to control costs will be greater.
So that's just kind of an overview of the Get With the Guidelines program for AFib. It already, a lot of the information, or some of the information, is already included in the stroke program, but it's just something, if you're having issues with the AFib and, you know, the 5 times increase in stroke is huge. We really don't want that to happen, and so there was an article recently that was published. Actually, it was just April 16th of 2018. It's in the American Heart News, and it's a call for deeper understanding of AFib, a growing and dangerous heart rhythm disorder. And again, you know, we're seeing more and more issues with AFib and not being treated properly. 50%, as he said, of the patients do not receive an anticoagulant that should be receiving it, which increases their stroke risk by 5 times. So it's really important that we address these issues with the patients and their families, educate them. Just to overview, you know that the AFib is the quivering or irregular heartbeat, where the upper chambers of the heart are just quivering and not beating appropriately. People can go in and out of it. When they go back, when they do that, sometimes that will release a shower of clots that cause a stroke. It increases the risk of blood clots. It affects 6.1 million people. That's a lot of people, and it's increasing because our population is growing older. Researchers expect that the number will double by 2050, and if it's untreated, AFib doubles the risk of heart-related death and increases the person's chance of having a stroke 5-fold. So again, it's a really important issue, one that we can continue to work on. And there again, I would like to stop. If there's anybody who has done something with your AFib stroke measure, can you please share what you did and the outcome of that? I'd really like this to be a little bit interactive. So *6 to mute, unmute, or type in questions or comments in the box, and Michelle will let me know. Is there any questions in the chat box, Michelle?
Not right now, but Chrissy did say that your timer idea is a great idea.
Hey, Deb.
Yes?
This is Allison.
Hey, Allison.
Hey, I just have a question for the group, and I might just maybe rephrase it a little bit. Since we know this is kind of an issue, and there's some hospitals that obviously are doing some great things, but maybe we could turn it around a little bit and hear from some hospitals who are experiencing difficulty with this measure, and maybe just to present a couple of ideas of why you think you might be having difficulty with the measure. Is it difficulty in identifying that patients with AFib and maybe not getting to them in time, or is it difficulty with the physician groups not following the guidelines and prescribing these medications? Are you getting pushback from physicians? Maybe we'd just like to hear some of your concerns or what you're running into as roadblocks. that other people might also be experiencing. And it's *6 to unmute. We really, really appreciate you guys' feedback on this. This is important to share with all of our colleagues across the 6-state affiliate so that we can all learn from one another. I know it's sometimes a little bit scary to jump off mute on a call this large, but it really is helpful to your colleagues.
Hi, this is James from Texas Health Fort Worth.
Hi, James.
Hey,
How
James.
are you?
Hi, good. Touching back on what we were talking about a little bit earlier, and then we can come back to the Afib. For the Arrive by 2, Treat by 3 measure, we found that we were able to take all of our missed TPA opportunities for 2017, and we were able to pull that data from Get With The Guidelines. And we reviewed all the cases individually to see if there were any common threads. And we found, probably not to any surprise of the listeners, that posterior strokes continued to be an area that we struggled with. And so our neurology stroke medical director took those cases to our ED division physicians. And as he started unfolding the cases, the ED physician started asking, well, what can we do differently? So our neurologist was able to give some practical guidelines on ways to assess and really tease out that dizzy patient to determine whether it's possibly a posterior stroke. And so from that, we've seen this year, we're running at 100% for that measure through the first 5 months of 2018. So we found that taking the education to the ED physician with the cases really helped them consider changes in their practice.
I think you bring up a really fantastic point, James, and that's something that Get With The Guidelines does a really good job of helping you to drill backwards on those cases and to go into a particular measure, pull those cases out to see which ones you didn't meet the measure on, and then, like you said, do a drill down to identify some common threads. And right off the top of my head, I know that in my area, I'm in Houston, we've been focusing a lot down here on missed opportunities with regard to mild and rapidly improving strokes. And so I think this might fall in line a lot of the times with the same patient population of those posterior strokes, that they just get misidentified or they get kind of lumped into this, mild stroke or rapidly improving, or just not those classic stroke symptoms that we always see. And if you're needing help to figure out how to get down to this patient list, I would encourage you to reach out to your local QSI director to have them help you pull that. It's really valuable to go back and sometimes paint a picture for your physicians or your leadership in your stroke program to understand better why it's so important that we are treating these patients. And the best way you can paint that picture, I think, is to tie the ends of the story together. James may know about this too, that a lot of times ER physicians are only seeing the beginning. They're not seeing the end result, so they don't know where the patient goes home to or if they go to a rehab facility or a SNF. So sometimes you just need to put those pieces back together for them and say, look, these patients that didn't get treated with TPA that were eligible, we had, X number of patients end up ultimately not being able to go home, or they were discharged with an NIH stroke scale that was higher or the same as what they came in with. So they were left with some sort of disability. So I think those are really good things to point out and to try to tease out of your data as much as you can. And of course, we're here to help you with that. So thank you, James, so much for jumping in and sharing that. Back to our Afib information a little bit. Does anyone have anything that they are running into, roadblocks or any issues with the Afib patient population?
So Devin put in the chat box that our low volume hospital, it is physician pushback.
Physician pushback, okay. And that's from a hospital, you said, Michelle?
Devin.
Oh, Devin. Oh, yeah. That makes total sense. I could see that being an issue in our smaller volume hospitals. But again, we have I think the good thing is with some of the smaller volume hospitals, you don't have as many maybe hoops to jump through with regard to hospital leadership and just the different dynamics within the hospital. So it also could be a plus. I mean, you have the ability to go straight to the people that are making these decisions and and to work with them directly and ask them why or how can we remedy this. So that's also a really good point.
Ours here, we're also from a hospital, and I've seen in ours, one of the things is getting the Afib mentioned in the chart in the appropriate place. I think it's overlooked sometimes because if it's on like a telestroke report, for instance, because they interviewed the patient, so they're taking that history, but then it's nowhere else on the chart. It's not on the EKG. It's nowhere else on the chart. I think paying closer attention to those areas.
So just to clarify, you're saying that the neurologist on telestroke is citing Afib in their history, and it's getting put in the record? Okay. And
sometimes,
it's not.
Or we've even had it to where our ER physicians, they've interpreted the EKG later on and added an addendum to the ER note, but at that point, if the addendum was added later on, then maybe the hospitalist didn't see that, and it's just, I know for us, it seems like to be a communication gap between the charting and ensuring that the next physician knows those important factors.
So I don't know how many of you utilize any kind of like dashboard reports or anything like that with your ER groups or your different hospitalist groups or whoever is seeing your patients. But sometimes these discharge measures can get away from us. You know, we worry so much as stroke coordinators about the front end. We worry about those really acute time-sensitive things. And so we're often presenting on these measures, you know, maybe in a dashboard format or a report card format to our ER physicians. And we're sort of leaving off these sort of end-of-stay type measures because we don't really think they pertain to them. But you bring up a really good point that sometimes it's the ER physician that is interpreting that information. And if this would pertain to them, maybe they would know to get on top of that a little sooner, to put that in their note that, hey, we're recognizing that Afib is showing up on the EKG, just so that it's at the forefront, and that way that patient is being addressed earlier in their stay. So exactly. I think that's a really great point.
Right. Great. Also, Allison Christie has implemented a monthly stroke newsletter in her hospital, and this month she's focusing on Afib and stroke.
Oh, fantastic. That sounds like a great idea. I'd love to hear more about that, Christine. Or if you're me too. If you're even willing to share an example of it, we would be glad to look at it and maybe share it with the group if you're willing.
This is Chrissy. I just started it a couple of months ago, just a way to get some, one place for stroke information instead of me sending out a bunch of emails all the time. I'm trying to consolidate a little bit, and so I put this together just myself, and I just find good articles and have resources on there. It is just for my hospital, but yeah, I could definitely share it as an example of what I'm doing.
I think that's a great idea. I actually try to do the same thing, Christine, because I know we bombard you guys a lot of times with hundreds of emails, it seems like, and for at least my local area, I try to put everything in a consolidated newsletter like that as well, just to give them, a one-stop shop. Here's all the things that are kind of coming up. And I do think you're right. It does kind of help to just bring their focus in a little bit on what's important. What do you really need to know right now? And I encourage you, if you ever have any questions or you need new articles to put in there, we are always coming across new articles that are being published. Or if you need links to primary source documents, we can always help you with that as well. So please feel free to reach out to us.
So Christine, how do you distribute that newsletter? Does it go to nurses, physicians, or how do you, who is the focus and how do you distribute it?
Sorry, I'm just trying to make my phone work. So we have our designated stroke units, and that's our progressive care unit, and then our ICUs. That's what we have, that's what's our designated. And I have all of the nurses on a little email groups that I've created just for me. And then I also send it out to my stroke committee members. And then I have a few stroke champions that I send it to. And so then I add a few other people, like my house supervisor director, just a few people, just to try to get it out there, and then encourage them to either post it or contribute to it. I get positive feedback regarding, yeah, I love that, but I have to say I don't get a lot of feedback regarding any questions.
Mm-hmm. Thank you for sharing that. That's a great idea, I think. I'm going to move on because we're going to be running out of time here. So this is a what would you do measure. So I was talking with a hospital, and we were talking about CSPK4 measure. And that measure is for the comprehensive procoagulant reversal agent initiation for the ICH patient. So the description is for that, if the INR value is greater than 1.4 at hospital arrival, then then they need to be treated with a procoagulant reversal agent. And it lists some of those. And the rationale is that it's a life-threatening disorder. So it's not only for patients receiving the oral coagulant, but it's also for patients with acquired or congenital coagulopathy who are increased risk for the ICH and hemorrhagic expansion. So the scenario for this particular patient was the INR was 1.47, so just barely over. The patient had a history of metabolic problems as well as clotting issues. So how would you handle something like that? The thing is the physician did not want to call out this measure or to do a lot of education because she did not feel it was appropriate for this patient to even be considered for a procoagulant because of their clotting disorder that they had. So how would you handle that? What do you guys think about that? Any comprehensives out there? I know one of the things that we had discussed with the hospital was that, there may be some other exclusion type of things and why would we do that? So I think this question was actually submitted to the Joint Commission to their standards and their performance measure question and answer area. So hopefully we can get an answer on that to see. But if there's anybody who had any experience with it or have seen this, we'd just like to really know about that. And so there is a place, it doesn't really give you options, but there is a place here that you can documentation that there was a reason for not administering it. But in this particular case, the physician didn't feel like she really needed to document that because it was not going to be, she did not feel that was appropriate treatment. So it was just something I wanted to bring up to see if anybody had an experience with it and whether or not you could share anything for the hospital looking for the information. Okay, so I'll move on. So another thing that I've had a lot of questions on recently is how to add hospitals in the Get With The Guidelines program. So actually, this is just a step-by-step. You will get this, but you go to My Account tab on your community page, and the far right of the screen, and then you can select Manage Code List, and then select the HAID list hyperlink, and then if you type in, you can type in into any of the columns, either the hospital name, their ID number, if you know it, their city, their state, or their zip code, and the hospitals will pop up. And then you can just save those selections so that when you're ready to do your charting or do your abstraction for where the hospitals maybe either transferred to or transferred from, then those areas will be pre-populated. So this is just more of an FYI, an FYI thing. And so then a few more things. Did you know? So the American Heart Association does have a member hospital network for all of the different stroke communities. So there's one for comprehensive, there's one for Mission Lifeline, there's one for primary, for acute stroke ready. So I'd really encourage you to set up this link or to check this link and to join it, because you can really use, it's kind of like the AANN one, which is very robust. The American Association of Neurological Nurses, they have the stroke lister, and there's a lot of really great communication, questions, sharing of ideas, and sharing things. So especially if you're the Get With the Guidelines and the Joint Commission hospitals, then this network would be really great for you to join if you, and in case you didn't know it, there is the link. The other couple things that I found was effective January 1 for the thrombectomy capable. There are now minimum volumes that were added for, the CSC, I'm sorry. So there is minimal thrombectomy volumes that were added just recently to that. So the link to that is right here. So if you copy and paste that into your search bar, then you will get that information. And then the other one is effective January 1, 2019, the Joint Commission will require data collection for 2 new performance measures. So this is now the measures starting in 2019, that the Joint Commission will be reportable. And I would guess that it would also be the same for the other, the DNV and the other certifying bodies, but I don't know that for a fact. But for now, I do know that the Joint Commission will be changing there. So they still have the 8 that they've always had. And then one of the outpatient measures is they want to start looking at door to transfer to another hospital. So for the LVOs, the MER eligible, the hemorrhagic stroke patients that need that critical time, that we're taking a look at the processes just like we do for the TPA administration. And the time is brain thing, that we also are looking at processes to decrease that time of door in and door out. So at this point, I don't know that there's really any recommendations. There are a few recommendations, but not really any scientific recommendations. So I think by collecting this information over the next year or so, we may be able to see, through the research, be able to see if there is the golden time to do that, and what the outcomes are as the times decrease. And then the other measure that will be required for the primary stroke is the CSTK1 measure, which is the NIH score performed for ischemic stroke patients. So again, this information is already in your PMT, so you may want to start taking a look at that. Actually, it is a part of the plus measure for the awards. So it's just something to kind of follow to, you can get a head start in seeing where you are baseline and what you can do to improve those measures. So those are effective, again, January of 2019. Next topic, Texas stroke rules. Oh my gosh, I have 2 minutes. Okay, so Texas stroke rules, the Texas has not had stroke rule review or changes since like 2008, I think it was, when the initial stroke rules were published. So now they're going back in and they're taking a look at it. They've taken some things out, like where it says the Joint Commission. Now it's more of a general statement. And this is just effective for Texas, but the Texas stroke facility designation, the state of Texas does designate according to the surveyors and what your awards are, and they do have certain rules. So the rules are simpler, but I would really encourage you, they're having stakeholder meetings, so they've had 3 of them so far, and there's one in Temple on August 3rd. In October and September and October, they will be having more of these meetings. They're just going to be going around. They're trying to meet with as many stakeholders as possible to get input before these go into law. So I would encourage you to kind of keep an eye on that website. This link here will take you to the resource document for the proposed changes right now, as of right now. And it's kind of the baseline document. So I'd encourage you, especially those in Texas, to attend those meetings when they're close to you so that you have a voice in what the rules will be. So quickly, professional education resources. Boot camp, I have a boot camp, the stroke boot camp series is a 15-week series. I think we're on maybe 8. We're about halfway through. The next one, which is scheduled for August 2nd, will be Get With the Guidelines, all of the things. So that'll be some really good information, demonstration on how to use the Get With the Guidelines and how to use it to the best of, your abilities and what you can really get out of it. So Allison will be presenting that, and again, it's on August 2nd. And then August 9th, it's Stroke Safe Passage from Our Place to Yours. So that one is going to be talking about transferring patients between primary stroke centers and comprehensive centers. What do each of them need to do? And Jamie Gessmeyer and Michelle Patterson will be presenting that particular stroke webinar. If you haven't, if you don't know about these or haven't registered for them, I would really encourage you to. But these are recorded and will be available on the AHA website. And so all of that information will be here in the slides when you receive those. There's also several Get With the Guidelines stroke, target stroke workshops and webinars. So these are just a few of them from 2017. So if you go to the Target Stroke website and then look down there where I showed you for the workshops and webinars, then you can download the slides, you can listen to the video, and you can review the transcripts on these. So there's the Target Stroke Putting Best Practice to Work recording, and then the endovascular reperfusion therapy video. I think both of those would be very, very good, as well as the endovascular therapy and TNT updates. So I would encourage you to use those resources. Again, I talked about every time the Guidelines on the Go mobile app, so that's the AHA Guidelines on the Go. You can download those. They're available. It's probably the easiest place to find them. When there's new guidelines, then when you log into your program, to the app, then those areas are pink, so you know that there's something new in there for you to review. And then just some important dates. Q2 DaytoDays, or data due to be entered and Get With the Guidelines is August 29th. We came up with these numbers as 60 days past the quarter. So October 3rd is Q-Court, the abstracts are due. The 30th is also, October 30th will be the next stroke quality exchange call. If you have any ideas, thoughts, things that you want covered, please reach out to us. Send me the information and I will make sure and get that covered. November 9th is the poster reception at Scientific Sessions in Chicago. And November 29th is when we'd like you to have your quarter 3 data due to be entered and to Get With the Guidelines. And this is so that you can, again, look at your awards and make sure that you have the information you need. January 29th will be the following stroke quality exchange call, and then March 1st, quarter 4 of the data is due to be entered into Get With the Guidelines. By the 29th, that's the final day to change anything that you have by reviewing, drilling down, seeing if there's other things that you can document. Once March 29th comes around, that's the final day. That's when the reports will be run in April, and then in May, the awards will be announced. And then April 5 and 6 is Q-Core, which is a scientific session kind of a thing. They have a new venue now where they're adding a Get With the Guidelines track for that, and so I think there's some really good information that will be coming out of that. So that's all I have. I went over 3 minutes, but if there's any questions, I'm happy to take them. Anything in the chat box?
No, Deb.
Okay. All right. Well, thank you, everybody, for your time, and I hope that this was helpful for you. And have a great rest of your day. Thanks.